All right, Greg, you got something there you want to go
Yes,
through?
I do.
We want your opinion and your involvement in this, if you would, please.
The question is asked, what is my exposure to liability? If there is a discrepancy that I do not specifically address in my dictated medical record or the electronic medical record, all I can tell you is this: nothing makes a plaintiff's attorney as happy as two medical professionals who have a different view of it on the chart. And so whenever you don't answer a comment that the nurses have made, just understand it will be a point which will be driven home to you. It makes it tougher to defend. There are certain things, by the way, which are absolute no-nos. No healthcare professional should write a negative note on the chart, particularly the nurses, without a reaction, i.e. to say, patient's still in pain, and then not to say Dr. Henry notified or somebody notified or more pain medicine given or whatever it is, doesn't make any sense. I actually have to go to defend a case right now where the last nursing note says, patient now can't move right arm, helped into cab. But how can you have that on the chart? See, you can't have that on a chart. Now she's discovered something. Better she hadn't seen the patient at all than to say, oh, now he can't move the right arm, so now I've got to help him into the cab. And it says that on the chart. Discrepancies are not good.
Actually, we had a case like that, too, where somebody had to be wheeled out. Whenever they have to be wheeled out, if it's not an isolated musculoskeletal injury that causes that, you've got some issues. They wheeled this person out. It was a person who had a laceration of sorts here or there around the head or neck, and the reason they wheeled them out is because the person, the nurses noted some weakness in the legs. Well, we'll take you up. Well, obviously this was a spinal, central cord kind of thing. They came back the next day, and they couldn't move hardly at all in the legs, and basically that didn't go very well. And there was that note about with the nurses. It just nailed us. It's like, why didn't you tell the doctor kind of thing? It's no good to write it down without telling the doctor.
In fact, it's sabotage.
Who has who takes the hit for that, though? The hospital and the nurse or the doctor?
Yeah, time out.
Both take the hit all the time. Both.
Time out. Whenever you go to court, all it is just adds another zero and two people who don't like each other who are now fighting. It's like when one doctor passes a case off to another doctor. Plaintiffs love that because now they can get them fighting with each other. And you'd say, well, it's not my fault. You know what? This is a whole package. And if the package goes down and you don't think you're not going to have to contribute to that, you're wrong.
I know the answer.
You know, it's amazing when we do our monthly morbidity and mortality rounds, it's mind-boggling. How many times two things are in the cases where there's medical mistakes and we're reviewing them. One, unexplained tachycardia. It's everywhere.
Unexplained vital signs.
Two, you read the nurse's note at triage and you say, well, this patient's got that. Mm-hmm. Then you read the doctor's note. It's like, are they seeing the same patient?
Right.
And then almost every case we go through, it was the triage nurse's note that was bang on, and there's nothing written by the physician to counter that. Like a nurse says, presents with squeezing retrosternal chest pain, you can bet your bottom dollar. In my note, I will say patient denies ever having had squeezing retrosternal chest pain.
That's crucial. I think that's critical.
But never mind legal cases, morbidity and mortality, I can tell you the disparity between the triage nurse's note and the physician's note is scary.
By the way, once you go to correct a note of another healthcare professional, do it very professionally. I will say, nursing note appreciated. You know what that means? Nursing note unappreciated, but I got to deal with it. And then I'll say, at the time of my examination, they said that pain actually was 3 weeks ago. What they're in here for today is X, Y, or Z. But you have to show that you recognized that some other healthcare professionals picked up another problem. What really looks bad is if you have not addressed an issue.
If you, it's interesting because I read we have a triage nurse who's dubbed somewhat fondly Dr. Ed, who writes the diagnosis, not the chief complaint. He writes his diagnosis up in the chief complaint box and then proceeds to do a triage note based on what he has decided is the diagnosis. So it is frequent that you must sort of address Dr. Ed's triage diagnosis. And we don't note appreciation of the nursing notes per se. We just specifically address everything that Dr. Ed noted in the triage note out there in our own history and physical.
That's fine. What I want to do, though, is show, and since I'm dictating them anyway, just say, nursing note read at this time, this is what I find, this is what I get, just to show that I have looked at the nursing notes, because nothing looks as bad as if another professional has written something detrimental, derogatory on that chart, and you are unaware of it when that patient goes home. That's the problem.
It's very time consuming to have to go over the nursing notes, but it is worth your while. You find all kinds of things. You flip through the nursing notes, it's like, were you going to mention the drop in systolic to 80 when the temp spiked at 103?
Right.
Kind of would have been nice to know about that.
Right, exactly.
In St. River Hospital, we used to always get discharge summary of the patients that we admitted from the ED, so you could see exactly who was sabotaged as far as some of the caustic comments on these individuals. I mean, it gave you a sense of exactly where some of these medical staff individuals.
Let me tell you.
Well, I think that I've seen some nasty, nasty stuff written by the attending physicians on the admitted patients. They are clueless to the medical legal implications, or if they're not, they're even malicious.
Yeah, that malicious is probably a better term. By the way, we have a rule at our place, and this is for the nursing staff, 100%. There can be no negative nursing note written after discharge. You know how the nurses sometimes stack up their stuff too and finish it up? If they've got something negative to say, it's got to be said to me, because it doesn't do anyone any good to have that sitting in the chart. I always love this. Patient's still in pain at the time of discharge. What am I supposed to do with that when the patient's gone home? See, if you're willing to write down a negative, here's the rule. If you're willing to write down a negative, you've got an answer. See if it says, oh, awake, alert, happy, feeling better, wants to go home, hungry. I don't care about that note. When it says the family still doesn't understand why we're taking poor grandma home, then it should say, Dr. Henry brought to the room to talk to the family. That's reasonable. But if you don't think those little notes can't sink your boat, they'll drive it right into the ground.
This one, this is the spider bite. You know, spider bites, at least where I used to work, that chief complaint was always, yeah, you don't use drugs. Yes, you do.
Yes, you do.
Spider bites were always skin poppers. Well, now spider bites are you, me, and everybody else on the planet who has MRSA. And I'm sure every hand in the room here. Actually, has anyone not seen a case of MRSA?
No, has anyone not diagnosed?
Well, no, I think most of you, well, whatever. The reality is it's everywhere. It used to be in these little pockets, and now MRSA is everywhere. And this sort of question is when a patient has a, quote, boil popping up all over the place on somebody's body for no apparent reason, they usually have MRSA, and that is absolutely true. The prevalence of MRSA in if someone comes in with a skin or soft tissue infection at Harbor, their MRSA positive rate when we culture them is 80%. We are so high now that everyone's getting treated for MRSA.
Exactly.
Everybody's getting treated. And the MRSA treatment, I have to tell you, it is evolving faster than we are as a specialty. It's faster than we are. And we don't know what's the best approach to this because we've kind of just been chasing our tails with this. What we do in our place is for first episode, what we think is MRSA. They haven't had it before and no one in their family has it. They get Bactrim. If they have a lot of cellulitis, they get Keflex, and they may get a little bit of Bactroban for their own nose. If they are a recurrent case, they also get Rifampin to take care of the carrier state, and they get Hibiclens from head to toe, as does everybody in their family, 3 times in the first week, to try to kind of eradicate this. Is it based on data? No, we don't have enough data yet. The good thing to know is a large NIH grant was just awarded to a multi-center trial that will be looking at, is there a best approach to this? Should we be doing something universally? I'm not sure they'll be able to come up with an answer, but at least they're going to be giving it a try.
And it's not in who you think it's in, because my last big group of these were high school wrestlers. You know, not injectors, nothing like that, clean cut, you know, all American boy kinds of things, and the whole damn team had MRSA.
There's a 11 hospital group that was put together to look at infectious diseases. Dave Talon, and they collected this, and they published it not too long ago about the soft tissue infections from 11 hospitals around the country, and 60% of all of the skin and soft tissue infections were MRSA. At that time, they said doxy, clindamycin, and Bactrim were effective in the most. in most of them.
Just a quickie, when you look for somebody like this and you're going to culture, you're not talking about somebody with one little spot of a folliculitis. You're talking about somebody who has multiple.
Doesn't necessarily have to be, actually. It depends on your patient population.
A spot.
Yeah.
If there's more than one, it's more likely to be MRSA.
I'm assuming these days that the cellulitis that I'm seeing is MRSA. Is that's what you're doing at this point? And I wouldn't have said that.
For more than one spot, if it's just like one little spot.
5 years ago, if you told me I was going to be treating MRSA with Bactrim, I'd have said you're smoking dope.
Yep.
And now we're using that and Clinda, and then unfortunately,
if they're sick.
yeah, Vanco if they're sick. And the problem is we've given out so damn many antibiotics that Clinda is starting to drop
can't
off in a
use
lot.
Clinda.
She can't. I still can. But it is very regional as to what you can use
Which is
on
why I
these
think
organisms.
this study is going to be a problem. The other thing to know about MRSA is it's no longer just confined to skin and soft tissue infections. The deeper infections also occur. We had 14 cases of MRSA necrotizing fasciitis at Harbor. And the latest scary thing is MRSA pneumonia after viral pneumonia, particularly after influenza. It's lethal. It has basically an enzyme that basically causes tissue necrosis, and it's lethal. We had 3 cases last year at Harbor of this, and the CDC has put out a little bulletin for the flu season when it comes this year to be careful with this potential community-acquired MRSA sort of secondary infection. Yeah.
And in last year's, go ahead.
Just to also let everyone know, I work in the ER department at the main hospital in Pensacola. We had a case of MRSA sepsis that died.
Yeah.
They did a similar
Community-acquired MRSA, right?
entire nation. So when looking at patients now, please don't forget constitutional symptoms. I mean, that's now in our mind. If you're looking at skin infection, if they're febrile, they have a high.
Was it a skin source that was the sepsis source?
It was the skin source that was the sepsis. The girl went into this, and I'm with you, in the active duty environment, actually 5 years ago or 3 years ago, when I was still on active duty in the Navy, we started to see MRSA in the barracks rampantly. I mean, 100% culture rates almost after a while. And so in the Navy, we were kind of ahead of the curve, but this one case of sepsis here basically took the entire organization. I mean, we now have it to the point that if an active duty kid has a skin infection with fever, we're hospitalizing them. We're not. We may be a little overreacting, but we had a case of someone died from it.
Well, yeah, one of the things, last year we did a thing about side effects of antibiotics, and now that you may be using more rifampin. Rifampin is one of the few drugs which has been shown to be associated with decreasing the effectiveness of birth control pills. Now, that concept of, well, broad-spectrum antibiotics may infect, that was generally disproven, except for rifampin. This one says, when will the Joint Commission define minimum standards for resolution on X-ray, digital X-ray images? That's interesting that you brought this up because it came up at our hospital. If you put your digital image on a Dell monitor kind of thing, it's not the same as what the radiologists are using. And there's a difference between a diagnostic quality monitor and a review quality monitor. And we have had 2 fractures which we think were missed by our emergency physicians because they were using a review quality monitor rather than diagnostic. So we have purchased, and it's $8,000 actually is what it's costing to add this into our digital imaging thing, so that the emergency physicians are getting the same quality images that the radiologists are getting.
I wouldn't do it any other way. We had the exact same thing. We now have the great PACS monitors right in our place. We're looking at the same thing. They're looking at, and by the way, the orthopods have all gotten these things now at home. They ain't driving in. And you know, we always carry on this discussion. Well, it's a little bit over here and kind of to the side. And they don't want to hear that crap. They just want the picture. Okay, a picture is worth 1,000 words to those guys. They've got them at home now. They just bring up the thing and say, yeah, I'm coming in for that one. No, I'm not.
So this may be a new potential liability issue if your docs are being asked to use a non-diagnostic quality monitor.
Your hospital should kick in then for diagnostic quality monitors in your ER.
Yeah, actually, our foundation bought them for us, and I know that because we got the radiology department to give us the bid on this, and it was $8,000.
But this has been a great change in my life because now I can push a little button, bring up the last 3 chest X-rays. They all come out on a row. There's no work. They're not digging for things in the film room. This is good. This is science making a giant step forward.
All right, unsurprisingly, there's a few questions about PE. I talked with Diane before, and I don't think we've ever done one of these where there hasn't been questions about PE,
Right.
and that's not surprising. So two of the questions focus around PE in pregnant women. In fact, I just had a case last week. And the literature has actually become much clearer recently in this than it was recently. And the literature has now come out and stated very, very clearly that we should not be doing lung scans. That the radiation risk to the fetus is much higher with a VQ scan than a CT is. There's more radiation to mom, but much more radiation with a VQ scan to the fetus.
Absolutely.
So that what we should be doing is, if we have suspicion, we do not do a D-dimer because it's falsely elevated in many pregnant women. We do ultrasounds of their legs first because if it's positive, we avoid any radiation. But if you're still stuck and you still think the person might have a PE, the only test you can do is a chest CTA. And that's what you're stuck with. And then I think that the VQ scan, this was sort of the last bastion of the VQ scan, and it's now gone the way of the dodo because of the most recent literature. What do you do? And I went through this the other day because I discussed this with a radiologist, and we both agreed that's what we were going to do. Then the second radiologist came along and said, well, you guys, it's never a PE in these women. You're always radiating them for no reason. I said, listen, the girl is 23 weeks pregnant. She woke up acutely short of breath with pleuritic right-sided chest pain, and her pulse was 115. I said, and you're telling me not to do it because you think clinically the chances of having this are very small? I said, that's why you're a radiologist.
Oh, yo.
So we did a CT, and it was normal. But, I mean, that's the steps you have to do. There aren't any other choices, unfortunately.
You know, I wouldn't write off of doing a D-dimer, and I just am looking for the negative. If I find a negative and she's pregnant, great. That's fabulous. And
In a low suspicion table.
yeah, in a lower, or maybe even an intermediate, I would do it.
But the problem is it's been shown that even in hypercoagulable states, such as malignancy, that you shouldn't use the test at all because it's got an 85% sensitivity. It becomes less sensitive in cases like pregnancy and malignancy. And in fact, where you think it would be more false positives, the sensitivity actually decreases.
What about urinally impaired individuals? That's the problem that we face quite frequently.
Comments?
Or renal impaired, and so this issue of contrast.
Qualify for CTA.
Oh, right, I see what you're talking about.
Well, and a young person, you might say, okay, well, we'll just do the perfusion scan. They're not going to have an abnormal ventilation scan.
The problem is always with the VQ scan, whether it's just a perfusion scan or not, of course, is that unlike when I started my career where the radiologists were absolutely dogmatic, there's no PE. There is a PE. I mean, now the VQ scan is basically 80% of the time, I'm not sure. And so it's only a good test in the young person who's really impaired if a normal is present and it rules out the disease. After that,
So I think his question is, what do you do then?
What do you do then?
I mean, you can go for the legs, and the data says that asymptomatic legs in someone who has a PE will be positive 7 to 15% of the time.
Right.
So you can go for the legs even if they're asymptomatic. But if you're right, the contrast issue is a big one. You can't VQ if their chest X-ray is fine, do the perfusion part of the VQ. You can look at the legs, but otherwise you're kind of stuck in those patients. There's no good answer.
You know what I do with those patients? I will start them on their heparin in the department, admit them, and then we'll let the pulmonologist debate.
Pass the buck.
Pass the buck. The next, but I'm serious. Sometimes these things have to work their way out, and I'm not going. What I'm not going to do is somebody who's got a reasonable probability, and I can't do the study of choice. I'm going to just go ahead and treat them. I mean, I don't know what else to do at that moment in time, and the pulmonologist will fight this out over the next few days.
Doctor.
I'm just wondering, is there any good literature of recent years looking at CTPA versus VQ?
In what sense?
Comparative.
I think that it's pretty clear across the board. What Jim said is correct, that on average, probably 70% of VQs will be in this indeterminate class, which is basically not going to help you. But, you know, that's a little bit that's taking the average. If when you're talking about young persons, they're not going to generally have any kind of lung disease that is going to anatomically screw up the ability of just a perfusion scan to show you whether there's an issue or not. So there have been some papers that have talked about the premature death of VQ scans because we're excluding these young folks. But across the board, the pulmonary angiograms are better, although their miss rate is probably in the neighborhood of 6%.
Yeah. By the way, CT angio and a true angiogram are a little different.
Right.
Now, understand that we will probably get a 5% miss rate with the CT angio, maybe 8%, something like that. But they tend to be off to the sides, very small, nothing big. But that's when the gold standard is. Then they've gone on to have a regular angio. And most people would think if you have a clean CTA,
You're fine.
You're probably okay. Would you agree with that?
Yeah.
Yeah, I mean, don't forget that the angiography studies that were done literally 2-3 decades ago,
Yeah.
no one commented at how poor the inter-observer agreement rate was. And that if anybody thinks that true digital angiography is a gold standard, they don't understand how poor it is. It's movement related. They can't do it with certain patients. If they're breathing too fast, they can't do it.
Right.
If the patient's unable to lie flat for a while, they can't do it. And the inter-observer agreement amongst people for digital angiography of the lungs is terrible.
Well, that's why they started doing these combined chest and leg studies.
leg studies.
Because if the chest was negative and they saw clots on the legs, well, then basically it was considered to be a false negative chest scan. And those numbers generally come out to be a 6% yield when you will see positive legs and negative chest. So it's a small number, but it's not zero.
Yeah, there is a Bayesian analysis of this, too. I mean, when somebody is 65 and they've just had their hip pinned, and now they've got pleuritic chest pain on one side, you know what? Some people would say, just go ahead and treat them at that moment in time.
Go ahead.
I guess that was my other question. Is the consensus pretty much that most people are not doing straight pulmonary angiograms anymore? If the CTA is negative, plus or minus $1.
Yeah,
Right.
Yep.
there is
Yep.
a belief that we don't do enough of them because what happens in this, you know, if you have a 6% miss rate in that neighborhood, what if you had somebody who said, this is a slam dunk pulmonary embolism. Look at all of these risk factors this person has. Look at all these symptoms. And for some reason, this angiogram comes out negative. There's going to be some subset of the population who say, this is just a false negative.
Mm-hmm.
And it would require a physician to say, I want the real traditional pulmonary angiogram done on this person because this is a dangerous diagnosis. They're going to be on medication for a long time. Now, it's kind of hard to conceive, however, that you would have such a big, clear-cut pulmonary embolism that it would not be seen. But if they make a mistake, they make a mistake, and it's your job to say, well, no, I'm not satisfied.
Which
we have
one of the
conflicting
things
data here.
That's come up in both of these comments is it is highly suggested that you do a risk stratification scheme. Whichever one you choose is up to you. But you need to have a pre-test likelihood to start from so that you know how good your tests are. And that's like the first step in anyone in whom you're considering the diagnosis of PE. I don't care which one you use, just use it consistently and document that, you know, we use whatever, Wells. Patient had a score of 6. I'm highly worried about this person having a PE, and the negative study isn't enough for me, versus they have a score of 2, and I'm going to get a D-dimer may be helpful in that situation.
Right.
Yeah, so saying, if you look at the literature, be it from Europe, from Canada, and the articles that have been published, have said fairly clearly, let's not worry about anything other than patient outcomes.
Right.
And the patient outcome studies say if you do a CTA and some type of leg study, be it CTA followed by CT of the legs or CTA with ultrasound of the legs, that your chance of having a PE in the following 3 months, if those two are negative, is less than 1%.
Less than 1%, right.
You've ruled out PE. So a CTA and some type of leg study. The study at Hospital Ivan, we just went down and did the legs. Other places do ultrasound before they do the CT. I don't care what you do, but if you've looked at the chest and you've looked at the legs and it's negative, all the literature to date says you've ruled out a PE and that you don't need to go on and do a pulmonary angiogram.
By the way, nobody knows how long these people should be on Coumadin afterwards. There's fights
That's
about
changing
this
a lot.
all the time. You know, we went through that. Well, it's 6 months, then it's this. What if they've got, this problem or that problem? It's a big issue.
Who's next?
Okay. Somebody asked the question, LP for subarachnoid hemorrhage. Evaluating xanthochromia without a photospectrometer. Understand this, just holding it up to the light is very difficult. Everybody's shown, all the studies have shown, that when it's positive, holding it up to the light, it's terrific. If it's negative, that's where you've got the problem. Positive is never a problem. Hold it up, that's pink, okay, not a problem. It's the negatives which are the problem, and your eye isn't that good. And I think pretty much people agree with that.
But nobody has these kinds of things here, and I think there was a paper in the database that talked about spectrophotoscopy or whatever determined this, and basically it said it wasn't useful.
Well, also, they did a survey that looked at, all the papers, the older papers say spectrophotometric xanthochromia is the single best rule-in test, except that 1% of hospitals in the country do spectrophotometric analysis. What they do is the tech goes, what do you think? Does it look pink? Does it look yellow to you?
It looks yellow to you, yeah.
Okay, fine. That's how it's an eyeball test. It's not spectrophotometric.
And by the way, it depends when you do the test.
It has to be 12 hours.
Yeah, because if you do it after 5 days, you know, we talked about that patient who came in and said, you know, I was on vacation, I had this terrible headache, my wife wants me to look at, when was it? 5 days ago. Well, you know what? Most of the xanthochromia is cleared by that time anyway. You could easily get a false negative on that one. They've cleared their xanthochromia. And it's not a simple question. And by the way, xanthochromia has to do with lysing those cells. So Jim's comment is right. If it's 2 hours ago, you're going to see red cells. If it's 12 hours ago, then what you might be seeing is the xanthochromia.
And, you know, along with that 12-hour window is also the fact that this ID, you know, remember we used to stick it in if it was traumatic, the number of red cells would decrease over the first to fourth tube. That decrease in red cell count is no longer considered valid.
Yeah, by the way, that was the next question here is, what is the acceptable number of red blood cells in the tubes? Well, we don't know that because...
But that's my question. I mean, it's my question, actually. I mean, I go down to a spectrometer, I do the right thing, I CT them, I tap these people, and then I've got 20 red cells.
And that doesn't tell you anything.
In the fourth tubes? In the first and fourth tubes?
Well, no, say I've got 100 in the first tube and I've got 20 in the fourth.
That doesn't tell you anything. It doesn't.
Well, it probably doesn't. It doesn't put you. It probably doesn't put you in what we would call a range where the safety is so good that you don't have to be worried about it. Yeah, it's probably better when your red cells went down, but nobody knows what those numbers are, or at least I haven't seen anybody who's actually documented that against whether they had true subarachnoid hemorrhage.
People actually angio everybody that's anything other than
No, but wait a second. No. Hang on a second. You don't. We do the scan and tap with varying thresholds, right? There is the thunderclap, clutch my head, vomit like crazy. That's a subarachnoid
hemorrhage. Yeah.
But we drop the bar below that classic thunderclap, horrible headache thing. We drop the bar some. And if you are doing it just because I'm a little worried, I want to make sure. I mean, there's this pretest thing as well. You don't have to go crazy taking all these people to the nth degree. If you were doing it to make yourself, I'm a little worried. I don't really think it's there, but I'm worried enough to check, and the red cells are clearing. You're right, it doesn't rule it out completely, but your pretest likelihood was lower, and we don't factor this in to the subarachnoid thing. It's a disease you do not want to miss. So a lot of us will tap people more than you might the 100% classic headache. The other option that you mentioned is angio, CT angio or MRA, which is what some people will do. The problem with that is that 1 to 2% of the population, 2 of you in this room, have a Berry aneurysm right now.
Actually, some people would say fine.
Right, if I were to MRA all of you, and you happen to have a bad headache today, is the headache from the aneurysm or not? So you are in this weird sort of stuck place. If you have an aneurysm, your neurosurgeon may say, 20 red cells doesn't mean that they bled. Well, it may mean they bled. I don't know if that aneurysm is what is just true and unrelated. It's a very complicated issue.
Even worse is that about 10 to 15% of subarachnoid bleeds are not related to aneurysms.
Right.
Right.
There's 10% we don't know
we don't ever figure out why they did it.
So is anybody using any kind of cutoff numbers? I mean,
I'll get you even more scared. There was a study out of Edmonton by Brian Holroyd and company that showed, thunderclap headache idea isn't true. It can be headache that has a rapid rise that takes up to an hour to get to its worst, can be a subarachnoid hemorrhage. And it's not this 1 second you have it, it can be much longer than that. And this notion that that is where, there it is, has been shown in that study very eloquently to not be the case.
Well, wait a second.
But
What that study actually showed was you can have other things. If you look at Ed Mead's data, and he looked at every subarachnoid hemorrhage in Ontario, still, when they actually give you the thunderclap story, it is something to think about. Sure. But there can be others, that's right. But that isn't to say that the thunderclap story is not a valid story. And I think, it's like the RR to 38 times or something. When they say at 12:42, bang, it hit me like a 2x4, you know what? I'm still impressed by that story.
If you're worried about presence and absence of red cells, and can't tell by clarity, why not just sit still?
The question is, why not dipstick if there was actually a study of Dalhousie that showed that's not reliable?
That's right.
Yep.
it would be nice.
Yeah, you.
I just want to follow up on Diane's pretest probability comment and what you would do with decreasing number of red cells, how more aggressively you follow that. Would you extrapolate that to your workup of subarachnoid in general? We do a lot of chart reviews in my group, and for about 2 years I carried the shield and the sword. I was looking at all the people who came with headache, and I mean, in my group, 80% of those were getting a CT, and then discharged home after a negative CT.
For what? Looking for what?
Exactly. Well, that's what I thought. What do you CT? Because it was for an acute
That's extraordinarily dangerous business.
And
Yeah.
so everyone, the response from the group, in the end, I think the way they decided to cover their tracks was the pretest probability was extremely low. And then if you
Well,
have
then
a
don't
pretest
get it.
probability that's very, very low, and then you had a study that was about 90% of the disease, suddenly you
But in fact, it doesn't. When you have a low probability, like the person who says, I was making love with my wife, my headache got really bad, by the time I came to see you, it's gone, I feel fine. Probably CT's only got about a 50% sensitivity. So when you have a small sentinel bleed, CT is not 93% sensitive like they say, it's only about 50%. The smaller the bleed, the less sensitive, and so the person you most need help on, the CT is a terrible test.
Yeah, it was like the CT gantry was sort of a resting place where they let their narcotics take just give them a couple doses, have the CT, come back, see how they're feeling.
Well, and I'll tell you that see how you're feeling. I mean, I'm sure it came up in the migraine talk. Is
It
the
did.
response to pain meds does not
Does not
say that
count.
It's not a bad.
We can
sleep.
take away pain in subarachnoid hemorrhage just like we take it away in anything else. So that is absolutely invalid.
I think the reason I mentioned the pretest probability thing is we reviewed that paper you were talking about where the headache threshold, it's not the thunderclap, it can come on over an hour. It is often described as a terrible headache, though. It is often described as a worst headache of life kind of deal. But we reviewed that paper, and what I found the residents were doing is they got wigged out, and they started working up, they dropped their threshold for working up for subarachnoid so low that they were getting traumatic tap positive patients that now what do you do? And it wasn't probably a subarachnoid to start with, and now you're chasing your tail.
But you see, at least
by the way,
in Diane's hospital, they're already xanthochromic when she sees
That's
them.
true. They've evolved out
Yeah,
the waiting
that's right.
room.
That's right. Yeah. I told you, it's too long a waiting time. If you come in with primary syphilis and you go home with tertiary, your waiting times are way too long. Just look and see how many patients that you tap, thinking they've got a viral meningitis, something like that. Actually, subarachnoid is not on the differential list. How many of those have red cells in them? We know that those people didn't have subarachnoid hemorrhages. The bottom line is you're going to have some red cells in all those people too. So if you stick a needle in, you will have people who will have some red cells in the fluid. That's the problem with overcalling this and doing too much of it. I mean, I think you really have to have some reasonable probability. By the way, those 80% who got scanned, did they all get tapped?
That's the point.
Yeah.
For non-traumatic head CT,
See, what you've just done is you've guaranteed to buy me another summer home someplace. Because when you get one of those that you didn't tap, and they ask you the right set of questions in court, you're not going to like it.
Write the check.
Write the check.
Okay, this one is actually, basically, the scenario is a patient with poison ivy comes in and has a blood pressure of 230/125. or they come in with an ankle sprain, or they come in with whatever. What do you do with an asymptomatic blood pressure of 230 over 135, 125 in this one? Bottom line is there are hypertensive emergencies, aortic dissection, acute MI with blood pressure out of control, pulmonary edema, blah, blah, blah. They're true emergencies. There are elevated blood pressures, and there's idea of a hypertensive urgency is vanishingly nothing. If you have, I'll tell you what we do at our place because we see neglected care. I just diagnosed a 23-year-old with end-stage renal disease because of untreated hypertension from the time he was about 13. Never got it treated. Now he's a dialysis patient at 23. We are very careful where I work as far as making sure the end organs I can't see in somebody who has this elevated of a blood pressure are okay because they often haven't been in the healthcare system yet. So what we'll do with this patient is I do not get an EKG if they're not having chest pain. They have LVH, I don't care. I don't get a chest x-ray if they're not short of breath or having chest pain. I don't care. I care about their kidneys. So we check a urine and we check a creatinine. Those are the two tests that we would check in this 230 over 125 patient. If those are normal, we start them on meds and we send them home. If those are abnormal, in our situation where I work, because we have very little access to care, we admit them. We get their blood pressure controlled within 24 to 48 hours, usually with oral meds. We do it orally, not IV, because it's not really an emergency per se. But we get them controlled urgently before we send them back out with meds. That's the practice I have to practice where I work to make sure that these end organs I can't see. We try to look in their eyes. That's one, the other end organ that you can kind of parallel the kidneys or the eyeballs. You can, although I don't think my residents can recognize AV nicking or copper wiring to save their lives, but you can look at the eyeballs as well. But you really need, I think, in this kind of situation, if it's an unknown hypertensive in the past, you really should find out what their renal function is. If it's somebody who's managed as an outpatient, I don't think you necessarily have to chase it. Call their primary doc and have them tweak their meds.
But she made no, what, go ahead.
We do.
Yeah, yeah. By the way, you can get in trouble in only one way here, and that is, and I've defended several docs on this. Nurse takes a blood pressure, let's say it's 175 over 120, but they're in for a sprained ankle. In fact, that's what this person was in for, was a sprained ankle. The nurse circled that on the chart. On the way out the door, the doctor said nothing about it. So now 3 years later, he's in renal failure. And he said, went to the doc and said, hasn't anybody ever taken your blood pressure? He says, well, they took it at that emergency department 3 years ago. So now he's in renal failure. Now they're suing the first emergency doc who see, you never ask a question you don't want to know the answer to, because now they've got something on the chart that they should have at least said one thing. You know, go, why don't you, your blood pressure's up. I'm not sure why today. Go see your doctor this week. Or here's the name of a doctor to go see, or however you want to enter into the system. What you can't do is forget about it. By the way, the other thing is I've seen people who have gotten all jacked out of shape want to drop that blood pressure too quickly. Any danger in that? Watch them stroke right out, have huge problems. They've gotten used to a head of pressure pushing in their arterial system over the last 20 years. The last thing they need to do is have a 40% drop in their mean arterial pressure at that moment in time. It's no good for their brain.
If you want to do something that's scary, you just go through the last 100 ER charts of patients who were sent home and see how many of those have hypertension, 140 over 90, that's the number, it's not negotiable, and how many of those people had high blood pressure and were not told anything about it when they left. There was a great study that was done 25 years ago, but I don't think the answers are any different now. They went through it just like that, found out all of these people who were sent home who had elevated blood pressures and were never told anything about it. The higher the blood pressure was, the less likely they were told that there was something wrong with their blood pressure. And the fact of the matter is that when we do blood pressures in the emergency department, it's got generally nothing to do with the reason that they're there. So if it's got nothing to do with the reason they're there, you must be doing it for some screening reasons. And to the extent that the number is not negotiable, I think there's some liability that occurs. We had a case that's very similar, where the kid basically had nephrotic something or other kind of thing. Blood pressure was high. Nobody paid any attention to it, and wound up getting into dialysis. And they basically come back and they just like Greg's case. So you will be very disheartened to see the fact that blood pressure is taken outside of the range of normal, and nothing is done about it.
By the way,
no referral, no acknowledgement, no nothing.
we take vital signs on everybody, and yet the Joint Commission's manual doesn't say that. What it says is, you shall perform appropriate, the adjective, physical exam, history, and vital signs. Appropriate modifies all three of those. I have no idea why you take a respiratory rate on a 19-year-old kid with a sprained ankle. First of all, we don't do it.
A temperature.
Or a temperature.
Maybe they're all getting their temperatures measured. All the kid comes in with a sublux radial head. This kid's temperature's being measured. And it's up the butt because it's only a 1-year-old kind of thing, you know.
Let me tell you the joke.
This is how we take care of this. We stick a thermometer up the butt. It helps the elbow kind of thing, you know.
We had two thermometers for a while. One was the ear thermometer, and the other one, you know, the standard one that we probe under the tongue. I asked one of the nurses one time, how did you decide which one you wanted to use? She said, when I don't care what the temperature is, I use the ear thermometer.
Go ahead.
From a legal perspective, though, is there any numbers that you don't want to charge discharge time per patient, seen for a sprained ankle? But again, from a strictly legal, not a medical perspective.
Well, here's the legal guy.
What?
Is there a number that?
I don't think there's one specific number. And you and I see patients all the time who are currently being treated for hypertension, who are in there for other reasons. If they're in the system being treated on medications, I suppose if I saw a 240 over 160 or something, I would call their doctor. But I don't think it's a number. I think it's, are they in a system? Are they being monitored? Is somebody going to follow it again? And when I get somebody in with clearly not being cared for, with relatively high hypertension, I'll call the doc I'm sending him to and say, what do you want me to start him on? And I'll just start them that night in the emergency department, but I'm not going to start them with an atomic bomb. No. You'd be amazed. Hydrodiol, something like that, it costs us damn near nothing anymore to make. And we can drop the pressure wonderfully on these people.
Statistically speaking, most patients who have hypertension will be on 2 medicines. So if you start them on one, you're not. I think it's a perfectly reasonable thing to do. It'll just save some time.
Right.
Is there any decent evidence that Xopenex is worth the money? I don't think there's any decent evidence, but Xopenex really doesn't cost very much. I think it's like $1 compared to 20 cents for albuterol. So I don't think there is any decent evidence, but by the time this breathing treatment is done, this dollar will be turned into $250, so I think that this is a spurious argument in terms of the dollar part. If you want to get into the evil isomer theory kind of thing, I don't think there's much to support that.
The next question goes along with that. There's the statement here about nebs versus puffers, and I think this is kind of neat because there's 2 or 3 things that come around this. The most recent EM rap with Mel babbling away says you just got to get them these continuous nebs. You know what? In Canada, in most hospitals, especially the closer you got to Toronto, nebs were banned.
Banned?
Well, because of SARS.
Oh, SARS, that's right.
Because SARS is a droplet-borne disease. And it was shown if you use nebs, SARS goes all over the entire department. So you better think about why you're using nebulized treatments, because any person who has a droplet-borne disease, your entire department is getting that disease.
Well, it's true. You could watch it from across the room.
Yes.
It's like shoo.
So that, never mind the efficacy, just contagious risk is why nebs have almost disappeared. And you should be thinking about that in your department. 2, the literature has been very clear that in mild to moderate asthma, as long as you give enough, I don't care how you give it. The idea that someone who's dying gets as much medication with a nebulizer can't be true for 2 reasons. 1, to get 5 milligrams of albuterol into someone through a nebulizer takes about 10 to 15 minutes. 6 puffs, which is what 5 milligrams is, takes me 2 minutes. So there's no way I can get as much medication in with a nebulizer as I can with a MDI and a spacer. 2, the droplets in an MDI spacer are much smaller than they are in a nebulizer, and it's been shown consistently with isotopic drops that the person who gets an MDI spacer gets much further down than the person who's in severe asthma who gets a nebulizer. And I can tell you that I have given somebody who was literally on death's door 17 puffs of albuterol, 17 puffs of Atrovent in 5 minutes. And the guy put his hand on me, he says, can we hold off for a second? He had 35 puffs in 5 minutes. And because you have 2 or 3 cancers, you have to wait 30 seconds for him to recharge. And at that point in time, his flow loop showed an FEV1 of 15%. And he was doing much better. And so these arguments about nebulizers, I think that the nebulizer is a way for you not to do anything. You just put it on the face and walk away. You have to have someone like an RT or someone right at the bedside to keep giving them. And you don't have to put it in their mouth. You just like when kids, you put a mask on the end of the MDI spacer and you just put the mask on them. And let me tell you something, every near-death asthma I've had in the last 10 years, I have turned around with a spacer and haven't had to intubate them. And I believe it is clearly superior to nebulizers.
Well, the literature that's compared them says that's the case. It's just a matter of giving equivalent amount of drugs. And if you don't give equivalent drugs, you're not going to get equivalent kind of a effect. But there is this issue here that we're so used to parents expecting that nebulization treatment be given that it creates the opportunity to show that little thing that you're giving them is equally effective when it's used in a somewhat different way. But there's often this resistance of, come on, let's give them this nebulization treatment, which is somewhat problematic because it's just a smoke machine. It is magic, but it is no better than, or certainly could be worse than.
By the way, anybody know whether our death rate in asthma has gone up or down? It's slightly up. We're very good at mild to moderate asthma. At the upper end of this scale, I don't think we understand the disease, and it may actually be a different disease, and the death rate is actually up. And believe me, if you're the parent of a kid who's been sent home from the emergency department and now they drop dead, it is not a good situation.
Yes. Those 10 minutes you have to do, you get your response, you see where you are, you get people rolling.
But I want to discuss that. You know, he says because you give the space, you can get them faster, you can improve them faster. I will tell you that any asthmatic you see who you have to give more than 2 or 3 sets of puffs to, and I give them every 10 minutes. I mean, that's what our national guidelines say you have to do. And I've given them oral prednisone. I've had to give them 2 or 3 sets of puffs, and they're better. They don't go home. No, 6. 6. So you know, we're talking, 18 puffs of Ventolin or albuterol in an hour, or 45 minutes, and 18 puffs of Atrovent in the same amount of time. However, don't make the mistake of saying you're better, go home. Please wait an hour, repeat the objective test, and you'll be amazed that about 15 to 20% of your patients are already deteriorating on their objective measure. They look fine, they're doing okay, but when you repeat it an hour later, you have to give them that hour. And if you're doing it, they're going to need at least 3 to 4 more hours, let the steroids start working, get more puffs on a regular basis before they can go home. And the big risk, and if you do this, I can tell you, you take a look at the statistics about admission rates and stuff like that. In the hospital I was in St. John, our admission rate from asthma was 2%. Our rebound rate was less than 1%.
That's because albuterol doesn't treat you, it just makes you feel good, right?
Oh, it treats you.
Well, no, it just expands you, but the problem is inflammation.
Sure.
So it just gives you time to fix the problem.
Well, some people, basically you can nebulize Decadron and in that thing. That was one of the things you could, people have talked about the use of inhaled steroids in the acute setting. And we actually did a paper recently that suggests that there is some value to that because these steroids are potent and they are vasoconstrictors. And to the extent that you have some edema of your airways kind of thing and vasoconstriction, it is shown that it's not a 6-hour phenomenon, that you can see a difference in a couple of hours with some inhaled steroids thrown into the mix as well. Yep. I think the only concern about giving the patient the aggressive emergency department treatment with an inhaler is that the parents will say, geez, look, I'm going to, that's 16 puffs, and they told me to give 2 or 3 every, kind of thing. So you have to tell them that you're on a closed track with a trained, a licensed driver kind of thing.
I'm a professional, don't do this at home.
It's a closed track.
The door, they have to be told, all the nurses, they have to know that this is not, the magic mist is not the treatment, right? So that at the door, everyone agrees that this is how we do it here.
Well, and it's also not something to do at home. I mean, the problem is if you wait with these kids that are that sick at home and you're doing puffer, 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 you'll end up with kids that die.
Yeah, so I do think.
That's a spurious argument, because folks, 10 years ago, I mean, there used to be, every kid was in prison at home with a nebulizer machine at home, okay? And parents got nebs when they came to the hospital, and parents didn't give 15 nebs at home to their kids. They didn't do it. They're not that dumb. They learn, they understand. So this idea that you've switched from nebs at home to an MDI spacer at home, they didn't give a whole bunch at home of the nebs. Why would they give a whole bunch of spacers at home? That's a spurious argument, because it didn't happen with the previous treatment. In fact, there was a campaign by us 15 years ago with the New Brunswick Lung Association to get all images of nebulizers at home off the internet, out of the New Brunswick Lung Association literature, because we went on an aggressive campaign to get all nebulizers out.
Let's more. Greg?
Why don't we, you want to just call it?
It's time.
It
It's
is?
time.
Yes.
I thought we have 3 minutes.
All right.
My wife does too.
What works to keep smokers from stopping smoking? Yes, patch anything. It's real simple. Stop smoking, be a bitch for 3 weeks, and get over it.
But,
But
well,
while they're in the hospital, what do you do to keep them from sneaking down the back stairs and outside?
What
I'll
was that,
tell you what
Greg?
we-
You lock the door behind them?
well, what we do is if they're coming in the hospital, I know they're nicotine dependent, I'll have them the nurse put a patch on them right in the department. And I don't think there's anything the matter with that, because you know what? I'm not going to fix their addiction right now.
That 21 milligrams does not work for your 3-pack-a-day smoker.
Well, that and a little Ativan does, though. I've done both of those things. You know, I can't solve every problem, and I understand when they're coming in the hospital, I've got to do something. But nobody's got a smoking room anymore in the hospital. You all remember when the VA hospals had a smoking room at the end of the hall? Yeah, they could smoke through the ostomy, right?
In the primary care literature, the drugs do help too. Was it bupropion and the patches are better than patches alone?
Yep.
But it doesn't work right away.
No, nothing works right away.
Nothing works right away.
This is two quickies. Unusual discharge from the vagina. Why do a rectal? God only knows. I have no idea why you would do that. There's a more direct way to approach the vagina. I think.
However, if there was an unusual discharge, I would certainly ask the patient.
Depends what the
Do you
unusual
have rectal
discharge
intercourse
is.
as well?
And
I
then,
ask the question.
and this is about NAC and IV contrast nephropathy. Are we wasting our time to give it, and if not, when to give it? My sense is the literature is really very, very kind of equivocal on that stuff, you know. I don't think it's a slam dunk. I mean, it's a combination of, well, give enough hydration, and I know some people still do it, but the literature doesn't seem to be particularly compelling that it works. Anybody else?
Are anybody's radiology departments setting up protocols for NAC? Are radiologists making noises about which patients they're going to want to have NAC on board before they give contrast?
No, our departments that I've worked in talk of using bicarb
Yeah, bicarb. Right.
and not NAC.
Okay, Diane.
It is equally.
All right, thank you.